Today I'm going to talk about sleep and circadian rhythms, which is a topic that I myself and my group at Monash University have been doing quite a lot of work in. My area is, I'm a neuroscientist, I'm also trained as a psychologist, and I have a research program largely at Monash in Melbourne, and I also teach sleep and circadian rhythms to medical students, neuroscience students, psychology students. And I also have a clinic, which I'll tell you a little bit more about as we go through the lecture, because there are several areas of sleep. In fact, there are more than 90 sleep disorders that have been described to date, and there are several of these that we are only beginning to understand the physiology and the treatment approaches as well. So we have a clinic at Monash that really is focusing on the sleep disorders that have received less attention clinically to understand the best diagnostic and treatment approaches for these. So what I'm going to cover is a little bit of information, firstly about some of the functions of sleep and the consequences of sleep loss, and then go on to talk about how we're currently monitoring sleep and circadian rhythms and defining sleep stages. And then finally, I want to go on to talk about how sleep is regulated. One of the main theories of sleep regulation currently is the two-process model, we call it, of sleep-wake regulation. And then something about the neurobiological control of the sleep-wake cycle and circadian rhythms. So why has sleep become a very topical, of significant topical interest in the Western world? Well, we know that the cumulative effects of sleep loss and sleep disorders are an under-recognized public health problem. Now, of course, people for generations have known that if we disturb sleep, the most immediate consequence is the person is sleepy, and perhaps there are some mood disturbances as well. But it's only in the last 10 years or so have we recognized that sleep disorders and sleep loss are associated with other significant physical health consequences and mental health consequences. So for example, I'm not sure if you're aware that sleep loss and sleep disorders increase the risk of hypertension, diabetes, obesity, depression, heart attack, and stroke. In fact, almost 20% of all serious car crash injuries in the general population are associated with driver sleepiness. And in the Western world, we then argue that driver sleepiness could be considered the largest identifiable and preventable cause of accidents in all modes of transport. It surpasses alcohol and drugs as a problem in terms of road safety. And so that underscores the major problem that sleepiness poses for us in terms of public health. In fact, if we look at all of the major causes of disease and health burden in society, we know that these conditions are highly prevalent and a significant cause of these problems. And that's why sleep disorders and sleep loss are receiving so much interest. In Australia and in the United States, the economic costs of sleep disorders has been quantified. And we know that I worked with a group of people at the Sleep Health Foundation recently to describe some of the economic costs and the modeling associated with sleep loss and sleep disorders. So in 2010 alone, we know that sleep loss disorders has cost the Australian economy a substantial amount of money. In healthcare costs, it's $818 million Australian dollars of healthcare costs associated with sleep disorders, $4.3 billion attributable to indirect financial costs. And the way that health economists quantify disease burden is they look at a measure called loss of healthy life or disability adjusted life years. And if they use that standard method to see what is the human cost of sleep disorders, it comes to a staggering $31 billion in just 1 year alone. And this is why the government is now investing very heavily in appropriate management of sleep disorders. Now, if we look at the health burden associated with sleep disorders and the economic costs, the sleep disorders that are most well studied are obstructive sleep apnea and this is, you can see here, representing a pretty significant proportion of the healthcare, of the economic costs associated with sleep disorders. And the green area is insomnia. And so these are two very different sleep disorders and two very different types of presentation clinically as well. But it gives you an idea of the relative proportion of the health burden in these two cases. Now, another group that we study very regularly, and when we talk about sleep loss and circadian rhythms, shift work is one of the key areas that we study. Now, what is shift work? Well, we all do some kind of shift work as doctors. Many of you will continue to work as shift workers at some point in your careers. And we know that if we sleep and wake at odds with the internal biological timing system, it exposes the body to significant risk of disease and a series of adverse consequences. A number of these have been described, and in fact this review taken from a paper published in Nature Review Neuroscience over 10 years ago shows some of the consequences of shift work. To give you an idea, in the Western world, we think about 15 to 20% of the working population are involved in some kind of shift work. So that's a pretty substantial proportion of the working population. Well, not surprisingly, these people report circadian rhythm disturbances, and you can see that the rhythm of body temperature, respiratory rate, hormone production, and so on, the menstrual cycle, are all disrupted in shift workers. We also know that sleep and core processes that regulate sleep are also disturbed, and we see fatigue as one of the most immediate consequences of shift work. But these other health consequences are receiving increasing attention in shift workers, particularly the mental health consequences, stress, anxiety, depression, and so on. In Scandinavian countries, there's been a consistent report of increased cardiovascular risk due to shift work. And in fact, this 40% increased risk of cardiovascular disorders is consistently reported in epidemiological type studies. Many shift workers report reproductive disturbances, so the rhythms that regulate reproductive processes are disturbed. Gastrointestinal disorders are frequently reported. In fact, when people travel across time zones, which is another form of shift work in some ways, we can see that one of the most commonly reported symptoms is gastrointestinal disturbances. Most recently, the World Health Organization classified shift work as a probable carcinogen. Now, that's the second level down from asbestos and so on, because of the increased reports among shift workers, particularly of breast cancer. A number of large epidemiological studies coming primarily from the United States, and one of the seminal pieces of work in this area is a piece of work called the Nurses' Health Study. And if you Google Nurses' Health Study, you'll see that that epidemiological study, longitudinal epidemiological study, has given rise to a number of medical reports showing the consequences of disrupted circadian rhythms, shift work, and also generally women's health as well. And that through that study, the link between shift work and cancer risk has been well documented. Also in animal models, where you can look at animal models of tumor growth and so on, disrupted circadian rhythms, and when you simulate shift work in rodent models, for example, you can see the increased risk of cancer. In fact, in one country, in Denmark, after the World Health Organization made this classification, nurses were being awarded compensation for developing shift work, so because of the clear evidence linking the two. Now, as a sleep researcher and a person who's interested in this topic, one of the first questions that I'm asked is, well, how much sleep do we need? As human beings, how much sleep do we need? And my best answer that I can give really comes from a series of studies, including a study that I did when I was in the UK, where what we did was, it's difficult to, when we ask people, well, how much sleep do you need? We get a variety of answers. If I asked all of you now to raise your hands if you think you need 6 hours of sleep, or 5 hours of sleep, or 8 hours of sleep, and so on. There'll be a variety of answers. But what we know is that the actual amount of sleep that you get per night doesn't actually reflect your sleep need. And one way we can try and uncover what your actual sleep need is by bringing you into a laboratory environment, hooking you up to the standard methods that we use to record sleep, which I'm going to tell you a little bit more about in a moment, give you ample opportunity to sleep and see how much sleep is achieved in these conditions. And so this is what we did in this study. I did the work in the UK, and you can see here what a typical sleep lab might look like in the UK, and you can see here the weather is not particularly nice. The environment is shielded from light and dark cues so that we can study people and their natural circadian rhythms and their sleep-wake patterns very easily. And so we recruited healthy volunteers, brought them into this sleep lab environment, and we kept them there for actually 13 days. So they lived in this lab for a long period of time. And what we did was, on each day of the study, we recorded their sleep. On the first day of the study, we let them sleep for 8 hours, the typical amount of sleep that people have in the general population or report needing in the general population. And then we measured how much sleep they actually got using these electrophysiological measures that I'll speak more about in a moment. Then we deprived them of sleep altogether for one night. And then from there onwards, for the rest of the study, we put them to bed for 16 hours each day. And the reason we did this is because we wanted to challenge the sleep system. You deprive the person of sleep completely, and then you give them ample opportunity to sleep and see how much sleep is achieved and what the pattern of recovery is like. And so when we did this, you can see the first day after the sleep deprivation, there is about 11.5 hours sleep achieved on average. And after that, this curve quickly plateaus and shows this asymptote at 8.7 hours. What we think means is that the requirement for a young healthy population, the sleep need, is about 8.7 hours. And this is consistent with work that was done in the United States as well when I was doing this work in the UK, that showed that somewhere between 8 and 9 hours is the typical sleep need of a healthy young adult. As we age, sleep need probably becomes less. And even though people show increased signs of sleepiness as they age, we can see that somewhat paradoxically, sleep need is actually decreasing as well. So the big question is then, why do we sleep? If we imagine now that we need somewhere between 8 and 9 hours of sleep per day, that means that 1/3 of our lives is spent sleeping. If we are fortunate enough to live till 90 years of age, it means we have slept for 30 years. Now, a very famous sleep researcher in the United States once said that sleep must play a very important function from a biological or evolutionary perspective, otherwise it's the biggest mistake that's being made in evolution, because how could we conserve a function like this that occupies so much time? A number of theories have been put forward. The first of these is to conserve energy generally, that we expend energy during wakefulness and we need a period of time in which energy is conserved. There is a series of theories that talk about enhancing survival, optimally timing behavior to adapt to the environmental challenges and needs. So we know, for example, that there are significant differences between nocturnal and diurnal animals. Animals that have activity during the daytime, like human beings, and are asleep during the night, in contrast to nocturnal animals that are asleep during the daytime and are awake through the night. And we think that this pattern of behavior is optimally timed so that the organism has maximal chance of survival, food availability, temperature conditions, and the way in which the physiology can adapt to the external environment. Increasingly, there's evidence that sleep plays an important function in restoration and repair of injury. So I'll be talking to you a little bit more about some work that we're doing with patients that have sustained a brain injury. and what happens to their sleep. And I'll come back to that in a moment. Most recently, over the last 20 years or so, there's been increasing evidence to support the theory that sleep plays an important role in memory consolidation and learning. Now, this is somewhat surprising to many people because the average person in the general population thinks that when they hit the pillow at night, the brain effectively goes offline and there's very little neural activity of any of any significant purpose. Actually, sleep is a very active process, and we see that during this time there is significant activity that goes on, including consolidating learning and general memory consolidation. So let me tell you about that brain injury study that I was talking about. So what we did was to test the theory that sleep plays an important role in recovery from injury. We brought a group of patients that had sustained a brain injury into the laboratory environment, and we compared this group of patients to a group of healthy people that were of similar age and gender. And so this is one of these studies that we call a parallel groups design. We have a patient group and we have an age and gender matched control. Now, the types of brain injured patients that we see in Australia and particularly in Melbourne where I live, the most common cause of brain injury in the adult population is motor vehicle accidents. So the vast majority of the patients that participate in this study would be motor vehicle accident patients. Now you can see all of the different sleep characteristics that we compared. And the one that I've highlighted, SWS, stands for slow wave sleep. I'm going to tell you a little bit more about slow wave sleep and how it's measured in a moment. But slow wave sleep refers to deep sleep that, if we look at an EEG trace, is characterized by delta waves. This is the deep stage of non-rapid eye movement sleep. If we look at slow wave sleep, we see that traumatic brain injury patients, even though they report increased fatigue during the daytime, they subjectively report more sleep disturbance, they actually obtain more slow wave sleep than the controls. You can see that on average there's nearly 24% of their sleep comprises slow wave sleep compared to the controls where it's about 19.5%. And that's a significant difference, an increased amount of slow wave sleep. And we think that this is evidence that slow wave sleep plays an important part in neural recovery. Let me tell you about some of the tasks that support the role that sleep plays in memory consolidation. And these are two key studies from about 10 years ago from a group in the United States that showed this important role that sleep plays. So the first, the upper panel shows a very standard neuropsychological task. It's called the Tower of Hanoi task. Subjects are asked, or patients or subjects are asked, to reposition the discs on one pole onto one of the other poles in a particular order, and there's a particular set of rules in terms of how the discs can be moved and what the configuration should be like. And the object is to move the discs over to the other pole in as few moves as possible. And so in this particular study, subjects were taught the task, they were retested a week after training, and we see spontaneously a significant improvement in performance. But if we experimentally deprive these individuals of rapid eye movement sleep, one of the core stages of sleep, the night after they train, no such improvement is seen. And so this was the first important discovery that suggested to us that what is happening in your sleep tonight is critical for consolidating the learning on the preceding day. That is, when you're, for example, studying for an exam, going to sleep after studying is going to be quite important because it's going to be important for consolidating the new learning. A separate study showed a different problem here. It's called a mathematical insight task, another neuropsychological task. In this case, the subjects are taught a complex algorithm for solving a mathematical problem. And unbeknown to them, there is a simpler solution to the problem. And so if you can see where I'm pointing, there are a series of numbers, there's a particular standard algorithm for solving the problem, and the numbers need to be, the solution that the subject is required to do is reflected in these numbers that are written here. Unbeknown to the subjects, there is a simpler solution, and it's called the insight algorithm. And the insight algorithm is that the last three numbers are a mirror of the preceding three. And so they only really need to solve the mathematical problem up to this point, because the latter three numbers are a mirror image of the preceding three. And what they found is that when the subjects are taught the standard algorithm for solving the mathematical problem, the simpler solution exists, which they're not taught, but these researchers were measuring how many of them discovered the simpler algorithm. During training, no one discovered it, but at retest, 12 hours later, a subset discovered the simpler method. Now, the probability of discovering the simpler method was more than doubled if the participant had sleep in the 12-hour interval. If they had no sleep, the probability was much less that they would discover this insight algorithm. So these findings, and if you look at the literature and if you Google sleep and memory consolidation, now you can see a number of publications from very high impact scientific and medical journals that show a significant body of work now linking sleep to new learning and memory consolidation. Now, very recently, the media attention about sleep has resurfaced because there was this discovery in animals to show that sleep may play an important role in what we refer to as flushing out toxins. So in these studies, what the researchers did was they looked using both imaging techniques, electrophysiological approaches, a number of approaches, to look at the differences in the plumbing system in the brain called the glymphatic system when the animal is asleep versus to when the animal is anesthetized and when they're awake. And what they found is that firstly, this glymphatic system increases in its volume during sleep, and there is more rapid clearance of toxins. So they, for example, looked at an amyloid protein, and they looked at clearance of amyloid, and amyloid is linked to Alzheimer's disease. And so they looked at the rate of clearance of this particular protein, and they found that it was much more rapid during sleep than during wakefulness. So the conclusion from this work is that sleep also plays an important role in clearing out toxins, and so therefore disruption of sleep, that is one of the mechanisms where they think that disruption of sleep could be linked to disease, such as Alzheimer's disease. So going back to then, what are the consequences of not getting enough sleep? Well, in the Western world, there is clear recognition that when we drink too much alcohol, there is an impact on your cognitive function. Now, more recently, there is an understanding that when we deprive the person of sleep, there is an equivalent impact on cognitive function. And a famous study that came from Australia and published in the journal Nature some time ago showed that if you're awake for about 19 hours, your impairment, your cognitive impairment on a simple reaction time task is comparable to the impairment that's observed when your blood alcohol level is at 0.05. 0.05 is the legal limit in many countries for driving in terms of the blood alcohol concentration. So that's suggesting that after 19 hours of wakefulness, your impairment is equivalent to the legal limit for driving in terms of alcohol, blood alcohol concentration. After 24 hours of being awake, your impairment, cognitive impairment, is comparable to a blood alcohol concentration of roughly 0.1%. that is twice the legal limit in many countries. And so this shows the magnitude of impairment of cognitive function due to sleep deprivation. Now, the other important consideration when we think about the consequences of sleep disturbance is that our physiology has the sleep-wake system has the it's not only tracking how much sleep we had in the preceding night, it's able to track sleep history over a significant proportion of time. And therefore, when we think about taking this work to a clinical setting, it's not only important to understand the person's sleep history on the preceding night, but we need to look back over several nights, because it's the system is we describe it as it has the capacity to accumulate a sleep debt over several nights. And let me show you how this has been demonstrated very elegantly, again in laboratory studies in which human volunteers come in and we study their sleep. So this was a study done in the United States by a group of well-known sleep researchers. What they did was they brought people into a lab and they randomized them, so they randomly allocated them to one of 4 different conditions. In each of the conditions, the variable that they manipulated was how much sleep the person was able to obtain on each night of the 14-day study. So in one condition, the group of participants that were randomized to this condition got no hours of sleep, 0 hours. TIB stands for time in bed. So they weren't allowed to go to bed at all. And so you'll be pleased to see that this didn't go on for 14 nights. This condition continued for 3 consecutive nights. And in the others, there was a 4-hour time in bed, a 6-hour time in bed, and an 8-hour time in bed condition. Now, what was measured was on each day of the study, so this is on the x-axis of this graph, you can see from baseline right through to 14 days of the study. What they measured was, well, if you give people this much sleep overnight, what is their cognitive functioning like on the next day? And they measured lapses of attention on a standard cognitive task. And this task, without going into the details, involves the participant staring at a screen and looking for a symbol that appears on the screen and reacting as quickly as possible. And the symbol is shown at random intervals. Well, if they miss the symbol, that's called a lapse of attention. Now, that kind of a task has important implications for the way in which, because of course attention is one of the core functions that's required for virtually every cognitive process, because we need to be able to maintain an adequate level of attention for several other cognitive functions. And so you can see that after one night of total sleep deprivation, no sleep, the person, the group of people on average has about 8 lapses of attention. After 2 nights, it goes to about 13 lapses of attention, and so on. And after 3 nights, it's just over 15. But look what happens to the group of people who have 4 hours time in bed, 6 hours, and 8 hours. Let's look at the 6-hour time in bed condition, because many people in the general population actually report about 6 hours of sleep per night. And you can see that in this condition, after about a week to 10 days, the number of lapses has increased to almost the amount of lapses of attention that occurs when you have no sleep at all. That is, a week to 10 days of 6 hours of sleep is equivalent to 1 night of no sleep at all. Now, this is a substantial level of impairment, and most people aren't aware that they are operating in this kind of sleep-deprived condition. You can, of course, we mask this kind of sleepiness by using caffeine and seeking stimulation, bright light and so on, can mask this endogenous sleepiness that is accumulating because of sleep loss. Most recently, in terms of talking about functions of sleep, so far we've talked about the importance of sleep for memory consolidation, recovery from injury, we've talked about the importance of sleep for maintaining optimal cognitive function. Recently, there's been considerable interest in, well, what role does sleep play in metabolism? And one of the clearest or the most significant areas of interest has been the link or potential link between sleep loss, sleep disturbance, and obesity. Now you're going to ask, what on earth does sleep and obesity have to do with each other? Well, in the United States and in much of the Western world, we see this enormous increase in the prevalence of obesity in the general population over the last few decades, and it's shown here in this graph with this very steep rising curve, and the curve here drops at the early 2000s, but there has been no change in the rise or the steepness of this curve over the past few years as the rate of obesity increases. Now, at the same time, if we look at the mean sleep duration, how much sleep the general population is actually achieving over the last 50 years or so, we see a decline. Now, you probably are aware, as good research scientists in training, that you can't simply look at two graphs like this and infer some kind of causal relationship, or as tempting as it is. And so you need to now do a number of research studies to really examine, is there a link between sleep loss and obesity? And one of the key pieces of evidence used a laboratory setting to test this hypothesis. Now, when we talk about obesity and research in obesity at the moment, one of the key areas in which, or the key measures that we take are the hormones that regulate appetite. Leptin and ghrelin are hormones that are very important in the regulation of appetite. Leptin is a hormone that signals increased appetite, and ghrelin indicates satiety. So in this study, people were brought into a lab environment. Again, they were randomized to one of two conditions, and they either had 2 days with 4 hours of sleep or 2 days with 10 hours of sleep. And these researchers looked at leptin levels and ghrelin levels after this particular intervention. And they found that 2 days or 4 hours of time in bed, that is inadequate amounts of sleep, resulted in lower leptin and increased ghrelin. And you'll remember what I said is that if you have lower levels of leptin and higher levels of ghrelin, that would predict increased appetite and therefore increased food intake. So one of the core mechanisms now that are thought to link sleep loss with weight gain and obesity is that the hormones that regulate appetite, the neuroendocrine regulation of appetite, is disturbed and would result in increased appetite and weight gain. And that's one of the mechanisms that's been described. And there are several other mechanisms that have been described that link inadequate sleep to obesity, to diabetes, and to cardiovascular disease and hypertension. And I don't have time to go through these in detail, but you can see that leptin and ghrelin, the decrease in leptin, the increase in ghrelin that I just described, is one of the pathways that results in increased food intake and therefore increased weight gain. But you can see there are several other pathways as well, physiological pathways and also behavioral pathways. Well, we all know that if we have inadequate opportunity for sleep, that means that we have more time to eat. And so because you have more time to eat, of course, there's going to be increased food intake. But there's also going to be reduced energy expenditure potentially because we're fatigued and therefore we may be less active. And so there are some behavioral pathways and several physiological consequences of inadequate sleep that result in either directly or indirectly obesity, type 2 diabetes, and cardiovascular disease. So I'm going to pause there in terms of talking about the consequences of sleep loss and now what we understand to be the core functions of sleep, and now move to how we actually measure sleep. And this is going to be very important when we think about going forward in terms of developing sleep and an interest in sleep clinically, of course the first thing that we need to be able to do is document a patient's sleep-wake habits. How do we do that? Well, the gold standard currently continues to be polysomnography. Polysomnography includes a series of electrophysiological recordings, EEG, EMG, and EOG primarily, and it can be done in the home and in the laboratory. Now, typically, to do this kind of recording, it required a laboratory environment. Every tertiary hospital, for example, in our area in Melbourne, would typically have a sleep laboratory that's kitted out with a system that can measure all of these particular electrophysiological outcomes in patients. And we call this a sleep lab, and they're very prevalent around the city. But more and more the government is asking us, as in the sleep community, to try and reduce the costs of bringing the patient into a hospital environment in order to record these outcomes and the cost of keeping them overnight in the laboratory, so that we're moving these studies to the home environment where possible. So where these are low-risk patient groups, move these studies into the home environment. And so polysomnography can also be done at home. And there are a number of ways in which you can train the patient, provide instruction with video instruction and so on to describe how electrodes are attached and the recording is taken. You can send the sleep technician, and in most cases you send the sleep technician to the patient's home environment in order to do the recording. So I'm going to come back to polysomnography in a little while, but what does it record? You can record sleep latency. If you want to document objectively how long it took for the patient to fall asleep, the latency to sleep onset. And that is a key measure of insomnia. When the patient is complaining that they have difficulties initiating sleep, for example, you want to objectively document latency to sleep onset and see whether it is in the clinical range or it's in the normal range. Total sleep time, how much sleep is achieved when the patient is given adequate opportunity for sleep. Sleep efficiency is a measure that's used by sleep researchers and clinicians to document and it's reported as a percentage. And so the percentage is calculated by looking at, out of the total sleep opportunity, how much sleep was actually achieved. So if you have 8 hours sleep opportunity and the patient only sleeps for 6 hours of the 8, then the sleep efficiency is documented as 75% because they slept for 3/4 of the time. And then, of course, we document the number of awakenings, wake after sleep onset or WASO, and increasing interest in terms of the stages of sleep, the proportion of sleep that is occupied by non-rapid eye movement sleep, rapid eye movement sleep that I was describing earlier. Now, as you can probably imagine, this is an expensive and cumbersome way in which we document sleep. Increasingly across the globe, there is interest in simplified measures of objectively recording sleep. And the most popular area at the moment is what we call actigraphy. Actigraphy uses typically a wrist-worn device where it has an accelerometer in it, and the accelerometer measures movement. And so what you do is you get the patient to wear a wrist-worn device. It's like a wristwatch that has an accelerometer in it. It's recording their activity, their wrist movements continuously, and there's an algorithm that then infers when the patient is awake and when they're asleep based on their body movements. Now, this is a very practical system, much lower cost, much simpler for the patient, and also has the benefit that you can record over a long period of time, which for many sleep disorders provides valuable information rather than taking just a snapshot for one night. Now, the actigraphy recording is becoming increasingly popular because across the world there are many devices now that are being sold by companies that are, or if we're trying to promote physical activity in the general population, there's lots of devices like Fitbit and so on that people are wearing that measures activity, but also gives the person feedback about their sleep. And so the proliferation of these types of devices means that clinicians are now being faced with patients coming to them saying, I'm a bit worried about my sleep because, look, I recorded it using my device and it's creating these problems. Subjectively, it's important to document the person's experience of sleep, because sometimes you record objectively what their sleep is like, but there's a discrepancy between what they describe as their subjective experience and the objective sleep recording. And of course, in the disorder insomnia, which I referred to earlier, the subjective experience of sleep is the key feature. So you're looking at the patient's complaint of sleep, the distress experience, primarily, rather than relying on the objective measure. And so we typically use a diary, and there are well validated diaries that ask the patient typically before they go to sleep to record a number of variables through their waking day, and then when they wake up in the morning, a number of variables relating to the preceding sleep episode. And then you use the sleep diary to calculate a number of these similar metrics like sleep latency, total sleep time, sleep efficiency, and so on, as well as their daytime sleep and sleepiness. There are validated instruments that are used clinically and in research for sleep quality assessments, as well as sleepiness and alertness scales. Now, polysomnography, as I mentioned earlier, relies on using EEG, EOG, and EMG. Now, these are used to record and document sleep and being able to stage sleep as well. Typically in a sleep laboratory in a clinical environment, there are also measures of respiration included. And the reason for this is because one of the most common sleep disorders in the Western world today is obstructive sleep apnea. For the diagnosis of obstructive sleep apnea, we need a measure of sleep as well as a measure of breathing, because obstructive sleep apnea refers to is a type of sleep disordered breathing where there is obstruction in the upper airway during sleep that causes intermittent hypoxia, arousals from sleep, and then has significant consequences both in terms of daytime functioning, but also cardiovascular consequences and mental health consequences. So obstructive sleep apnea, the diagnosis of obstructive sleep apnea requires all of these standard polysomnographic measures, but also respiration measures. But today I'm going to focus on the polysomnographic standard measures. So what do these different stages of sleep look like on an electroencephalographic trace? Well, firstly, you can see that when we go to sleep at night, the first thing to note is that we don't just plateau and then suddenly fall asleep and the line goes down and then it increases and goes up as we wake up. You can see that from the time we go to sleep, there is a brief period of wakefulness, which should be very short in a healthy person, and then we progress through stages of non-rapid eye movement sleep until we get to fairly deep non-rapid eye movement sleep called N3, which is slow wave sleep. And then after a period of time, we come out of non-rapid eye movement sleep and we enter rapid eye movement sleep. Now, this cycle of non-rapid eye movement sleep and rapid eye movement sleep is about 90 to 100 minutes in duration. It's referred to as an ultradian rhythm because it has a cycle length that is substantially shorter than 24 hours. And so it shows this kind of frequency of 90 to 100 minutes. It continues like this through the night. And you can see a REM episode occurring approximately at that frequency. But what happens is as we continue through the night, the REM, non-REM cycle tends to be, the proportion of REM increases as the night progresses. So in the early part of the night, as you can see from this trace, most of the non-REM, REM cycle is occupied by non-REM sleep. As soon as we go to sleep, the body achieves non-REM sleep first, and there's only a little amount of REM sleep. But as we progress through the night, you can see that the amount of REM sleep increases and the amount of non-REM sleep decreases. Now, you can also see the marked differences in the EEG trace in REM sleep and then in non-REM sleep stages N1, N2 and N3. N3, of course, is the most easy to distinguish from the others because you can see these clear delta waves in the EEG activity. High amplitude, low frequency activity. And there are hallmark signs of the other stages as well, which I won't go into detail, but it gives you an idea of what happens is that after the sleep study, there is typically a period of time in which the analysis of the sleep recording takes place. A trained technician, uses standard scoring criteria to determine firstly whether in 30-second epochs, whether the patient is asleep or awake, and if they're asleep, what stage of sleep that they're in. And so that scoring of sleep is then used to derive all of the metrics I referred to earlier, such as sleep latency, sleep efficiency, total sleep time, and the proportion of each of the sleep stages. So moving from sleep recording now to talking finally about some of the mechanisms of sleep, one of the most prominent theories of sleep currently is that sleep is regulated by at least two physiological processes. One of these is called the circadian timing system. Circadian comes from a Latin word that refers to circa dien, which is approximately circa, meaning approximately or about, dien meaning about a day. So circadian refers to rhythms that have a duration or frequency of approximately 24 hours. And these rhythms are internally driven, regulated by a number of oscillators and pacemakers in the body. The master oscillator or pacemaker is located in the hypothalamus in an area called the suprachiasmatic nuclei of the anterior hypothalamus. And so this is one of the key processes that regulates the sleep-wake system. And of course it's important because we know that this biological clock or circadian clock is important for generating and maintaining time information throughout the body, including for the sleep-wake cycle. But there's also another sleep-wake process, and that's called the homeostat, and that's sometimes referred to as the individual's sleep-wake history. And I referred to sleep-wake history earlier when we were talking about how to document and measure sleep. Well, we know that your sleep-wake history is an important determinant of your current level of sleepiness and also your sleep-wake cycle. And both of these contribute to your sleep-wake state. We know that the circadian process is largely, although it's internally driven, it's strongly influenced by the light and dark cycle. This is why when we travel rapidly across time zones, as organisms we're able to adapt to a new time zone, and our circadian rhythms are able to adapt because the light-dark information in the new time zone is used to resynchronize the internal biological timing system to the new sleep-wake cycle and the new time zone. The homeostat refers to, for example, it's tracking how long it has been since I woke up this morning. It is tracking how much sleep I got and the quality of sleep on the preceding night and the recent history of sleep. And my vigilance level or my alertness level is partly determined by these factors that are associated with sleep history. And there are a number of neurochemicals that correlate with this kind of homeostatic process. So when the reason this conceptual model of sleep-wake regulation is important is because, firstly, there's been a lot of experimental studies that have supported this conceptual model, and so that's why it is still our current way of thinking of how sleep is regulated. Secondly, when we think of disorders of sleep and trying to understand when a person presents with sleep-wake complaints, and we need to try and now formulate some kind of hypothesis as to what is the cause of their sleep complaints, it's important to consider these physiological systems, because we need to understand which system might be disturbed in an individual to give rise to the complaints. Now, what happens with these two processes in ordinary physiology is that in a healthy sleeper is that they work in parallel to promote good quality sleep at night and when we're awake to promote alertness. So let me illustrate how this has been described. So when we wake up in the morning, the circadian signal it starts to increase and progresses throughout the day until the early evening hours, when the circadian clock is generating a strong arousal signal in the brain. Somewhat paradoxically then, the circadian system is generating its strongest arousal signal shortly before we're about to go to bed. Now, if I was giving this lecture live, I typically ask the students, why do you think this is? And we think this is because when we evolved, as many organisms of the course of evolution, we know that this period of time immediately before we go to bed is an important time for the organism to be vigilant and alert. And so therefore the circadian system promotes a stronger and stronger arousal signal, because over the course of the day, the homeostatic system, the other process, increases, and it's increasing the drive for sleep as the day progresses. So on the one hand, you have a process that is increasing the likelihood that the person will fall asleep, because the sleep drive is increasing. It's tracking how long the person has been awake, and the drive for sleep is increasing. In contrast to this, the circadian process is gradually increasing the arousal signal to offset the drive for sleep that's produced by the homeostat. Shortly after this peak in the circadian arousal signal, the pineal gland starts to secrete melatonin, and we think that the onset of melatonin secretion is an important signal to dampen the circadian arousal signal. And so you can see that coinciding with the onset of melatonin secretion in the pineal gland is a decrease in the circadian arousal signal. And what happens is that in normal physiology is that the circadian arousal signal declines, the drive is at a very high point, and the individual then can very quickly fall asleep because the arousal signal is decreasing, sleep drive is at a high point, and they quickly can fall asleep at the optimal time. So this illustrates, in terms of the physiology of sleep, how we think the two processes of sleep interact with one another, oppose one another, to produce an optimal amount of sleep, consolidated sleep during the nighttime, and optimal wakefulness, or the quality of wakefulness during the daytime, in an alert state. Now, looking at probably my favorite topic is circadian rhythms, and circadian rhythms, as I described, circadian timing is one of these core processes that regulate the sleep-wake system. So most of my work is focusing on not only how the circadian system functions, but what are the consequences of disruption of the circadian system. One of the key areas in which this becomes, or one of the cases in which this becomes very obvious, is if we look at shift workers that have very profoundly disturbed circadian rhythms. But another case in which disturbed circadian rhythms is receiving increasing attention is in adolescence. We see in adolescence there is a typical pattern of delaying of circadian rhythms as the individual enters puberty and then goes through until early adulthood. The circadian system gradually delays. Now, what we're seeing more and more, particularly in the Western world, is a greater prevalence of pathological delay of the circadian system. That is, that the system delays so much in its timing that the individual finds it difficult then to function in terms of their normal school life, for example. Now, this delayed sleep pattern, which we refer to as delayed sleep-wake disorder, has a high likelihood of resulting in not only impaired alertness and sleepiness during the daytime, but it also has significant associations with depression. And so much of the work that we're doing at the moment is looking at how do we develop interventions for people who have these abnormally delayed sleep patterns. It's not just in adolescence, but it's most prevalent in adolescence. But how do we develop interventions that resynchronize the sleep-wake cycle and the circadian timing system, and then reduce the risk of depression, or I suppose develop an adjunct to the treatment of depression. So looking then more at circadian rhythms and their fundamental physiology, we can see that many processes in the body are rhythmic. The melatonin rhythm, the plasma or the pineal synthesis and secretion of melatonin shows a clear circadian rhythm, but also a number of other processes, physiological processes, core body temperature, triglyceride levels, as well as cognitive function. And I've talked about performance on a reaction time task. If you keep a person in a controlled environment and measure their reaction time, you can see this marked rhythmic function. Now, we know that the rhythms are regulated largely by what we call the master pacemaker in the suprachiasmatic nucleus of the hypothalamus, and this shows the location of the SCN, or suprachiasmatic nucleus, just above the optic chiasm, bilateral here to the third ventricle. And we know from several lines of evidence that these densely packed group of nuclei here are very important, play a very important function in terms of the generation and the maintenance of circadian rhythms, and also the integration of timing, of environmental cues. So, for example, the light-dark cycle, the information from the external environment is perceived, of course, by the retina, and then integrated with circadian timing at this SCN site. So we know that the circadian timing system consists of retinal input of light information to the suprachiasmatic nuclei of the hypothalamus, and this master pacemaker is responsible for generating timing information throughout the body, and one of its core outputs is this multi-synaptic pathway to the pineal gland, where it regulates the timing of melatonin synthesis. And there are several lines of evidence for this, and I won't go into the detail here, but largely from animal studies. Well, neuroanatomists, the first thing they want to do when they want to demonstrate that a particular structure has an important role is they lesion the structure, and they look at the consequence of lesioning. So complete bilateral lesions of the suprachiasmatic nuclei abolish many circadian rhythms. Now, what's remarkable, and I guess one of the things that really drew me to this area of study, is when I looked at the studies that have shown not only that lesioning of the SCN abolishes many circadian rhythms, but that when we take the SCN tissue from a fetus and transplant it to a lesioned animal, we can actually restore rhythmicity. And that is remarkable, that this transplant can has the capacity to then restore rhythmicity in an animal that has lost its circadian 24-hour rhythmicity. We know that the temporal organization is lost, but not the function itself. That is, when you lesion the suprachiasmatic nuclei, the animal will still sleep and wake, but they'll sleep and wake at much more almost random intervals without a clear 24-hour pattern. So the SCN is playing a clock function. It's not necessarily generating the particular function. It's not generating sleep, for example. And then if we look at in vivo and in vitro neural and metabolic activity, they persist in isolated SCN. Even if we cut off the SCN from other signals, there are still 24-hour rhythms in neurons and in metabolic activity. Now, the last few years has received a lot of attention in terms of how light information is perceived by the clock. I talked earlier about how the retina plays a key role in transmitting light information to this internal clock. Well, you know that light is an important increasing interest in a separate photoreceptor mechanism. And this separate photoreceptor mechanism is called the circadian photoreceptor system that takes light information to non-visual brain areas. That is, that our brain has evolved to not only have a visual photoreceptor system, is to use light information not only to support normal visual processes, but also a separate system that supports the timing of our behavior and physiology to match the external environment. Now, there is a distinct group of cells in the retina that transduces this light information to the SCN, and this group of cells, intrinsically photosensitive retinal ganglion cells, are relying largely on blue light. They're maximally sensitive to blue light to signal to the SCN. Now, this has led to quite a lot of work in when we look at people that have disrupted circadian rhythms. One of the primary things that we do is we use light as a potential therapeutic intervention to try and correct their circadian rhythms. Now, there's much more and more evidence accumulating now to not only use light for circadian rhythm disorders, primary circadian rhythm disorders, but there are a number of trials that have been published to show the effectiveness of light therapy for other disorders, psychiatric disorders, for example, seasonal depression. Thankfully, in Sri Lanka, there isn't this marked fluctuation in the length of the day due to seasons, as we see in particularly the northern latitudes. In Scandinavia, for example, you can see these marked differences in the length of the day in winter compared to summer. And in winter, the change in day length, the shortening of day length, in some individuals can trigger depressive episodes, cyclical depressive episodes. And the cycle length is of course, an annual depressive episode. And so light therapy has been used effectively in these situations to reduce the severity of depression and the depression onset. Now, even in non-seasonal depression, light therapy is being used to reduce depressive symptoms. And we have successfully used light therapy to treat fatigue symptoms in patients with brain injury, for example. And the light therapy we use is 45 minutes of morning bright light exposure and we've documented in a randomized controlled trial the reduction in fatigue symptoms that occurs over a 1-month intervention period. Now, of course, in countries like Australia and cities like Melbourne, particularly over winter, we need to produce light, or we need to administer light therapy using an artificial light box. But of course, in places where light is abundant in the mornings particularly, you can use natural light to try and administer light therapy. 45 minutes is typically used because of the fact that it's difficult to get a patient to comply to light exposure for longer than 45 minutes, particularly if we're using an artificial, a light box that they need to sit in front of. Now, the reason I bring this up here in reference to the physiology I was referring to is that when companies that are producing light boxes for use in therapeutic situations are now enhancing these light boxes with blue light. So the light is increased in its blue content because we know these intrinsically photosensitive retinal ganglion cells that transmit light information to the circadian clock are maximally sensitive to blue light. And so to achieve maximum effect, the light boxes are being produced with increased blue content. I'll leave that. So I think what I'll do now is just conclude by covering the key points that we talked about, and that is that we've talked about some of the core functions of sleep and the consequences of sleep loss. We talked about the fact that sleep disorders and sleep loss are now increasingly being recognized as a major public health problem. Governments are investing significant funding into not only researching this problem, but also increasing clinical skills in this area. Because of this burgeoning problem in the population, there need to be adequately trained clinicians to effectively manage sleep loss and sleep disorders and the health risks posed by that. In virtually every health discipline now, there is an increased interest in sleep. And so in medicine, for example, in Australia, there is an independent specialization called sleep medicine. In Australia, sleep medicine came from respiratory medicine because of the fact that many respiratory physicians became increasingly interested in obstructive sleep apnea and then gradually started becoming interested more broadly in functions of sleep. But in the United States and Europe, sleep medicine has evolved very much from other areas of medicine, for example, neurology and psychiatry as well. In psychology, in dentistry, and so on, there is increased interest in sleep in those clinical areas as well. Polysomnographic monitoring of sleep and definition of sleep stages. This is a very rich area in which now we understand that we can measure very carefully and very accurately sleep, but as I was describing earlier, there is increased pressure to develop simplified methods now so that we can cater for a much broader and larger number of individuals in the population. Finally, I finished by describing some of the key models that are being used to explain how sleep and wake are regulated, so that you can understand what some of the consequences of sleep-wake disturbance are at the physiological level. Now, just to conclude, I want to talk about the area that we're working on at the moment at Monash. We're recognizing that insomnia and circadian disorders are becoming increasingly prevalent in the population. So insomnia, as I described earlier, is a symptom, but it can, and the symptom can manifest as either an inability to fall asleep, difficulty initiating sleep, that is, difficulty maintaining sleep, earlier awakenings that awakenings that are much earlier than desired, or even poor quality sleep can be referred to as insomnia as well. Now, insomnia was previously thought to be largely a symptom of a number of other health conditions, particularly mental health conditions such as depression, where sleep disturbance, particularly insomnia, is highly prevalent. In more recent years, we've recognized that insomnia is actually an important and can be a precipitating factor for depression, and so therefore should receive attention clinically independently to depressive symptoms. Insomnia is also linked to a number of other adverse health consequences, enormous losses in productivity and so on, but clinically has received much less attention than, for example, obstructive sleep apnea in countries like Australia. Circadian disorders are becoming much more, have received much greater interest, for example, from the psychiatric community, because of the very high proportion of patients with psychiatric disorders that show disturbed circadian rhythms. And so there is increasing evidence that these disturbed circadian rhythms, not only the sleep-wake cycle, but the other physiological rhythms that I described earlier, disturbance of these rhythms have clear consequences in terms of not only sleepiness, but also mood outcomes. And so circadian type interventions will, I think, over the next decade, become much more a part of mainstream clinical practice. Light therapy, for example, is one of the key ones that is receiving increased interest across the globe. So we have established a clinic that focuses very much on these two areas, insomnia and circadian disorders. And so that is an area in which we're continuing to develop both the diagnostic approaches as well as the circadian and insomnia interventions to more effectively manage these conditions. In insomnia, cognitive behavioral therapy for insomnia is now well documented to be an effective treatment approach for insomnia management. So our group is working very hard to refine and develop a model of delivery of cognitive behavioral therapy for insomnia that can be used by not only psychologists and sleep physicians, but also a number of other healthcare providers, considering the high prevalence of insomnia. So I think I'll leave it there. Thanks for your attention.